Good evening. My name is Holly Volz. I'm a fourth-year medical student here at UTESCA, and I've had the privilege of being co-president of the Benjamin Rush Society here on campus since we started in 2012. The Benjamin Rush Institute started 4 years ago as a project of the Pacific Research Institute, which is now a separate nonprofit organization. We are an organization that aims to unite medical students, residents, fellows, and physicians from across all parts of the political spectrum who believe that the profession of medicine calls their providers to serve their patients rather than the government. We believe that the doctor-patient relationship is a voluntary and mutually beneficial one. Both parties have the right to enter it freely, and the proper role of government is to protect this freedom, not to diminish it. Our goal is to provide a platform for civil discussion and debate on healthcare policy so that we may ultimately unleash the power of medicine to maximize human flourishing. Our vision is the achievement of worldwide, affordable, quality healthcare in an age of accelerating medical innovation and excellence. I'd like to take a brief minute to introduce our officers. Co-President Marco Mavromaris, First Vice President Nick Friedberg, Second Vice President Mark Pollock, and our Secretary Jeff Schroff. Tonight, we are honored to be hosting an exciting panel of scholars who are well-versed in healthcare policy, and it is my privilege to introduce to you Dr. Fred Campbell, our moderator for this evening's debate. Dr. Campbell is a graduate of Baylor College of Medicine. He completed his internal medicine residency at UCLA in 1980, and then he spent 4 years serving as a volunteer for the National Health Service Corps in Taylor County, West Virginia. In 1984, Dr. Campbell moved to San Antonio, where he served as medical director for the Southwest Medical Group and later joined and practiced with Brook Hollow Medical Group. Dr. Campbell joined University Health System in 2003 and is currently a practicing internist with UT Medicine in San Antonio. Additionally, Dr. Campbell is a writer, lecturer, and instructor in integrated practice under the Global Capitation or Medicare Advantage funding model. And with that, I turn it over to Dr. Campbell.
Thank you very much, Holly. I do consider it a real privilege to be here tonight. And I want to thank Holly first for promoting me to a full clinical professor. It says professor on the flyer, but I don't know what the dean would say about that. I'll talk to him later. As you, I think, already know, the resolution tonight is healthcare markets are not unique and do not require extra government intervention in order to function. I'm supposed to comment a little bit on that resolution. I have written and taught and lectured on various aspects of economics, but I don't have any advanced degrees in economics or public health or medical administration or ethics, so I'm a perfect moderator. And instead of trying to get into this myself, I'm going to let the pros take it. I do want to mention Dr. Benjamin Rush, who I just think is an incredible person. I've heard about him all my career. Dr. Rush, of course, was a colonial physician and was one of those people who signed the treasonous document, the Declaration of Independence. So a very courageous person, and I know that Dr. Rush would look down favorably on a bunch of male landowners talking about the welfare of minorities and women. So it's, not a whole lot's changed in 237 years. Let me introduce our panel. Starting on your right, Professor Avik Roy, Professor Mark Pauly, and those are in the pro. On the con, Professor Sam Richardson and Professor William Sage. I know that you've seen the bios on all of these gentlemen. They certainly can mention where they're from and why they're here, but I'm going to dispense with that because we already have a tremendous number of questions pre-submitted, and I'm even going to dispense with my part of the question and answer period, and as soon as the debaters are through with the formal part, we're going to move right into questions and answers, and feel free to bring questions down during the debate and to use the microphones later. Okay, with no further ado, I'd like to start the debate off on the pro side with Professor Mark Pauly.
Thank you. Well, I bring greetings from Philadelphia, which was the home of Dr. Rush, except when he spent some time in Carlisle, Pennsylvania, founding Dickinson College. But for most of his life, he was in Philadelphia, and that's where I am. I actually expressed to Holly some trepidation about a debate. I actually tried out and didn't make the high school debate team, because when I got up there, I said, on the one hand, the affirmative seems to have a reasonable argument. On the other hand, the negative seems to have a reasonable argument. And to that point, they said, you better be an economist. So it's worked out okay. So I won't be, I will make comments that are more focused on the second part of the resolution. Extra government intervention is needed, and be skeptical about that, but I won't be doctrinaire about it. And in the Q&A period, I reserve the right to backpedal if needed. However, one point I do want to make, which is actually a most germane, in most of these questions about what should the role of government be, my fundamental concern is that we don't have the evidence really to support a position one way or another. I know a lot of you are learning evidence-based medicine. Evidence-based health policy would be a wonderful thing if only it could come into play. But in this particular instance, many of the key pieces of information that you'd need to come to a firm conclusion about what the role of government ought to be just isn't there. So in many of these contexts, I don't know what the role of government ought to be. But I do know for sure that nobody else does either. So that will be the position I will take in part of the debate. Let me give a specific illustration of the role of nihilism here and how it can actually be helpful. So Kenneth Arrow is a world-famous Nobel Prize-winning economist, one of the nicest people in the world. If you were to be in a lifeboat, you'd much rather be with Ken Arrow than Paul Krugman, let me tell you. One of the points that he made, one of the aspects of his article, his classic article that has come into for some criticism, deals with the fact that essentially the strategy that he followed there was the strategy that economists tend to follow when analyzing the role of government. We have a wonderful, beautiful theory of competitive markets. Arrow actually contributed to a major extension of it from the deterministic world to a world of risk, and showed that competitive markets can in principle solve all the problem of allocation of risk. What you do then, if you're an economist, especially in Arrow's time when he wrote the article, if you look at the real world, you see that oftentimes in healthcare's Exhibit A, not all of the competitive preconditions are satisfied. You come to the conclusion, therefore, the market will not achieve the theoretical optimum, and you conclude, and therefore, the government should step in. And that's because economists assume that government is run by people whose goal is to maximize the welfare-weighted sum of individual utilities, or, in the words of Jefferson, by omniscient angels come down to earth. And I think it's fair to say that economics has moved somewhat away from that market failure paradigm over the years. And in particular, I'd like to mention Ronald Coase, a Nobel Prize winner and teacher of one of my teachers in Virginia. And one of Coase's main points was, you can't settle these questions about the role of government and the role of markets in theory. You have to look empirically about how they perform. And so in the real world, we're choosing between the better of two imperfect methods of doing things almost always. And the question is, which is the better of a bad situation? And I guess it's probably pretty obvious, not to pile on, but to point to what's been happening with health reform. There were some problems with the individual market. It was unlovely in a lot of dimensions. There were some real issues. But at least in the short run, it's hard to believe that what's going on with the rollout of the website and health reform is going to be an improvement over that. At least we don't have the data to prove one or the other, and that's kind of my position here. I don't want to be a total wimp and say it all depends on data we don't know, so we're all confused, but still don't make a definite statement. I will make a definite statement that I make in every speech about the role of government. Government should at least stop doing things that do harm And the main economist's criticism of what governments do is the tax subsidy to employment-based health insurance. If you're working for wages, and I get an enormous subsidy, relatively speaking. Of course, I deserve an $8,000 subsidy to help me afford health insurance as a full professor at the Wharton School, and I respond to that by choosing the most generous plan. Take my subsidy, please. So that's one thing government should stop doing. But I have a longer list of things government might think of doing but need to be qualified. But let me just go to what I think is the most important one. And again, I'm going to slip into the language of economics. And it has to do with what I think is the most important part of the Affordable Care Act, which is the subsidies to lower middle income people. And the question is, why do that? Why does government have a role in subsidizing these people? The economic jargon version of that is good, specific, altruistic externalities. What that means is, translated into English, our species seems, at least most of us, maybe Scrooge McDuck is an exception, programmed to believe that if one of our fellow human beings is suffering in a way that could be relieved, we ought to do something to help them. And if the reason they're suffering is because they can't or won't buy adequate amounts of medical care, one way to get them to use more medical care is to cover it with insurance, and therefore they should have more generous insurance coverage than they might choose on their own. There's a limit to that. I don't need more generous insurance coverage, but a lower middle income person does. And there's also a limit. You don't necessarily have to subsidize all those people who don't have insurance coverage. Some of them you could mandate. But the main punchline here is there is a case for government intervention. But back to my main theme, the two pieces of information you'd need to design that sensibly are, what is the impact of insurance coverage on health outcomes? We really don't know. And I can go into detail in the Q&A. I hope somebody will ask. But the most recent data are even more confusing about how much good it does. And secondly, what are taxpayer values? How much does it bother you if your fellow citizens are not using adequate amounts of medical care? I can't tell you what your values ought to be. I'll kind of summarize, though. In my vision of an ideal healthcare system, it would be one where, first, you abolish or cap the tax exclusion. Second, you make sure that people get income condition catastrophic insurance. And third, you declare victory and pull out, of course, always reserving the thought that more research is needed.
Thank you, Professor Pauly. The second to speak will be Professor Sam Richardson in the con.
No? I'll speak loudly. I'm on now? Okay. So, in the beginning of Arrow's paper, he talks about the conditions under which competitive markets result in efficient outcomes. And to take some liberty with exactly how he presented those, to present them in a way that is more typically presented today, markets perform well in the absence of market power, so where everyone acts as a price taker in the market. That is, we don't have monopolies, we don't have providers or insurance companies who have power over pricing. There aren't information asymmetries, so there can be information problems where if I don't know the quality of a good, then my value of that good in the marketplace will not, the price will not reflect what the value is if I don't know what the value is. I'll speak a little bit more specifically about each of these things in a minute. And the third, I just had to have a Rick Perry moment there. The third is externalities. And Professor Pauly brought up what I was going to say is the most important externality here in healthcare, which is that we don't want our fellow humans to die because they don't have access to healthcare. It imposes a negative externality on me if people are dying in the streets. It's even worse for the person dying in the streets. But the market failure comes from the externality where it's bad for the bystander to have people suffering. When people typically talk about externalities, they talk about things like infectious disease, where my son's classmates, they don't properly treat the lice in their kids' hair, so my son gets lice, which happened this week. And or if people don't get vaccinated, they get infectious diseases, and they can pass those along to other people. Those are real externalities, but I think that those pale in comparison, and Arrow talks about those, and I think those pale in comparison to the moral obligation to give people access to a certain level of medical care. In terms of market power, to go back to my the first of my 3 points, we have in some areas of the country, in more rural areas, there can really only be one hospital supported in that area. It's what's called a natural monopoly, where it's not efficient to invest in a whole bunch of hospitals where there aren't a whole lot of people. In a case of a natural monopoly, we have a hospital which, if unregulated, would be able to charge monopoly prices, drive prices above what they should be in a competitive market. And then finally, to talk about information problems in healthcare, it is hard for me to know the quality of my doctor. To go back to my story about my son, before he was born, we went looking for a pediatrician. And we could figure out certain things about the pediatrician. We could figure out, did we like the feel of the office? Does it seem like the pediatrician will be available to us when we call in the middle of the night? And we soon figure that out when we do call in the middle of the night, as panicked parents do. But we don't know, is this pediatrician going to catch the disease? Is the pediatrician going to refer our son at the right time? And there's lack of information, and it's not the case that we can get that information through our own means. That being said, I agree with Professor Pauly that that doesn't necessarily mean that it is the place of government to step in. So we don't have the conditions where the private market ends up with efficient outcomes, but we do have, but we also don't have enough evidence to say that government will necessarily do better. So it could be that the government cure is worse than the disease. I tend to dispute that, but I think that I'm also not doctrinaire on this issue. That being said, if we look internationally, the U.S. has the least government involvement of major industrialized countries. We still have a whole lot of government involvement in our healthcare system, but we have the least compared to most industrialized countries, and our health outcomes rank behind the majority of industrialized countries. We spend roughly twice as much as other industrialized countries do on medical care, and we certainly don't have better outcomes than they do. Our life expectancy is behind the pack. And so I think that we need to ask, what is it that these countries with more government involvement are doing right compared to what we're doing wrong here?
Pro will be Professor Avik Roy.
Thank you, and it's great to be here. My father was on the faculty here, Arun Roy, until 2003 when he passed away. In fact, the last time I was on this campus was for his memorial service that the faculty organized in this very room. So thanks for having me. We've been using a lot of economic jargon to talk about what we're trying to get at here, which is effectively this. What Ken Arrow wrote about 50 years ago this year was he made this argument that healthcare was different, that while the classical economic forces that we think of that work in every other industry do things like give us better and cheaper smartphones every year, or better, cheaper laptops every year, the fact that staples like food and clothing are much cheaper today and much more plentiful today than they were 50 years ago, that the forces that drive those factors and those things are not true in healthcare because healthcare is unique. Healthcare is special. And that's the core of his argument. And that argument, I regret to say, is profoundly wrong. And it's not only profoundly wrong, but it has been profoundly influential in particularly academic health economist circles and has had profound influence on health policy in the United States and many other places. Now, let me explain why I say that. And I know this means I'll never get a job at Wharton. Let me take five 5 things that Ken Arrow, and remember he's writing in 1963, so 6 years after we figured out what the double helix was, he's writing about the future of our entire health economic system. But he made these 5 arguments about healthcare, among others, in this paper. The first is that healthcare is unique because it's unpredictable. We don't know when we're going to get sick. The second was that there are barriers to entry, because doctors have to be licensed, they have to graduate from med school. That's different than a lot of other sectors of the economy. That there's an importance of trust, that, if a surgeon operates on you and he messes up, you could die. That's really important, so that's very different from other things. He talked about asymmetrical information, the fact that a doctor probably knows more than the patient about a particular disease, and therefore the patient is uniquely disadvantaged in that setting. And he talked about the issue of payment, the fact that with most things, you buy a TV, you take the TV to the checkout counter, you pay for it. That's not how healthcare works. You go to the doctor, you get a bill. The fact that you've agreed to pay for all the services that are provided is assumed. And if you have insurance, of course, it's technically paid by someone else, which creates another distortion. So those are 5 of the main things that Ken Arrow talks about as distortions in the healthcare system. But they're not unique to healthcare. So we have car insurance to protect us against a drunk driver who crashes into our car. That seems to manage without having nationalized the auto insurance market. There are barriers to entry in all sorts of fields. Lawyers have to be licensed. They have to graduate from law school. We haven't nationalized to create a single-payer legal system. Maybe we should, but we haven't. The importance of trust. When I flew here from New York City, I had to trust that the pilots were competent. If they didn't, I would die. But we have a system of regulation that allows us, and litigation that allows us to compensate for that. Asymmetrical information. Yes, it's true that physicians generally know more about disease than patients, but the funny thing is not always, and particularly not now. In this internet economy, I find when I talk to a lot of physicians, if there's a kid with Lyme disease, his mother knows more about Lyme disease and all the research that's going on in Lyme disease than your average primary care physician. And primary care physicians often dread seeing those patients or their parents because they know they're going to get quizzed on all the latest stuff that this mother dug off the internet. So the asymmetry of information is there, but again, that's true in so many different areas of the world. When we take our car to the car mechanic and the car mechanic says, you got to replace your transmission, he knows a lot more about how transmissions work than I do. But I just choose to trust him or I don't. When I buy a cell phone, I have no idea how GPRS works. I don't even know what GPRS stands for, but I have confidence that I can buy a cell phone and it's going to work. So then the last thing, and this is, I think, the most interesting thing, is Ken Arrow says, well, it's really unique about healthcare that we have this third-party system of payment where we give premiums to an insurer, and that insurer then pays for our health costs. And of course, that does have a tendency to create a lot of inefficiencies. The way I could try to explain it to people is like, it's the difference between a cash bar and an open bar. If you go to a cash bar, you're going to drink less than at an open bar. Typically, at least I might, And I'm going to probably order the single malt scotch if I'm at the open bar, whereas at the cash bar, maybe I get the Bud Light. It depends on whose open bar it is, right? If it's the in-laws' wedding, I'm definitely having the single malt scotch. So that's the inefficiency that third-party payment creates. So what does Arrow recommend in response to that inefficiency? Not to reduce it, but to increase it. He says, well, because third-party payment is so inefficient, let's have fourth-party payment. Let's have the government pay the insurers who then pay for the claims instead of having less insurance, having insurance truly be catastrophic, where if you get hit by a car, you get hit by a bus, you have a stroke, you get covered for that, but having the rest of your health expenses paid for more directly through things like health savings accounts. That's what places like Singapore do. They save an enormous amount of money doing that, and we can learn from what other countries do in a pro-market direction. So the point is that the incentive structure of markets that make smartphones cheaper and better every year work in healthcare. We just don't let them. Thank you.
Thank you, Professor Roy. We'll move ahead to Professor William Sage in the con.
Hi, everybody. Actually, Mark, would you mind switching over there? I don't see this direction. really. And I'll still ignore you, but this way at least I'll see you before I ignore you. Thanks. Let me start by saying clearly where I stand on the proposition. Then let me talk a little about Kenneth Arrow and this article that we really do celebrate, and I'll tell you about my involvement in work regarding the article many years after it was written. And then at the end, let me sneak up on you with a little bit of core health policy in terms of what I really believe. So the proposition that you were confronted with is healthcare markets are not unique and do not require extra government intervention in order to function. And I am firmly opposed to that, but for a reason you might not expect. I'm opposed to that. I believe that healthcare markets are unique and different, but I think the reason is that our society has declared them to be so, and has declared them to be so by a lot of people over a very large number of years. And so we are confronted with a situation where to describe healthcare as simply identical to everything else, I don't think gets us anywhere, and therefore I oppose the proposition. Now let me step back and talk about Kenneth Arrow. We really do need to celebrate this. This is an article written in 1963, so 1 year after the FDA amendments that responded to the thalidomide crisis were adopted, 1 year before the World Health Organization issued its Declaration of Helsinki, 2 years before the Medicare and Medicaid programs came into existence. So it describes a very different healthcare system than the one we currently occupy. I worked about 10 years ago, so roughly the 40th anniversary, though we made that kind of a contrivance, on a special issue of Journal of Health Politics, Policy, and Law. I'm a MD JD. I was working with a JD Econ PhD and another economist on this, with many, many contributions. And we were all grantees of the Robert Wood Johnson Foundation, and RWJF had kind of supported get-togethers among large numbers of grantees to do special projects. And they wanted us to do something on competition versus regulation in healthcare. And we thought, well, you know, everyone does things on competition and regulation in healthcare, and they never seem to really get us anywhere. What might be different? And we were just thinking about Arrow's article, and we realized that everybody had read this at some point, in whatever their discipline who were involved in this health policy. They'd all read the article. Many of them really didn't remember it or misremembered it, and that'll be a point I'll raise in a couple of minutes. But we thought it would be great to look at health economics and health policy through the lens of Arrow's article. And it's a fascinating article. First of all, it's written with words that express ideas, and that's become unfashionable in the economics literature. And so it's actually very interesting to see someone who's a great economist struggle with concepts and express the ideas in English. Another is that this was actually one of 6 products that the Ford Foundation supported in the early 1960s. It was then the Department of HEW, Health, Education, and Welfare, and they thought they'd get 6 economists to address problems in health, 2, education 2, and welfare 2, and they divide this between theoretical economists, 1 in each domain, and then empirical economists, 1 in each domain. Kenneth Arrow was the theoretical economist who was asked by Victor Fuchs to write about healthcare, and his contribution is the only one that I think has had any staying power from the 6. Kenneth Arrow, in the course of the article, writes about information and writes about insurance and writes about marketability and writes about not just government, but non-market social institutions, non-governmental ones. Now, one thing that's interesting, you may know Kenneth Arrow in 1972, at a very early age, won the Nobel Prize in Economics. And one of the things that was kind of formative in him winning the prize was his work in the economics of information. And you may think that 10 years earlier or so, he wrote this article because he was interested in information and saw an opportunity to apply it to healthcare. Something you probably would not guess is actually writing this article was the thing that got Kenneth Arrow really interested in information economics. And in some ways, what his great achievement was in economics that earned the Nobel Prize was a derivative of confronting the healthcare system, rather than him thinking that, if all you have is a hammer, everything looks like a nail, a phrase we in medicine tend to apply to surgeons. He really was inspired to a career worth of work. So that's kind of the personal. Now, here's the problem with what we're discussing tonight. So in the preparatory material, see, now I'm going to start ignoring you, because I just felt I had to give people a little bit of history of why this is a great article. So in the preparatory material, I was told, or we were told, that Arrow stated, quote, "The laissez-faire solution for medicine is intolerable." He did not state that in the article. Actually, in a section of the article, it's really just about the traditions of medical licensing and the like. He said the following, and this is a direct quote. He said, "It is the general social consensus, clearly, that the laissez-faire solution for medicine is intolerable." In other words, he wasn't making a normative statement. He was making a descriptive, an empirical, though a casual empirical statement. Says, we don't do laissez-faire medicine because we don't. And everything that he writes about is an attempt to explain why we don't, and then think in the context of higher healthcare costs and the benefits of insurance, how we might actually do better. But Arrow never once endorses direct government intervention as the only solution, and only thinks of it as one quiver in the arrow, and no pun intended, one arrow in the quiver, I should say, of health policy. In fact, what he really draws attention to are these non-market social institutions, voluntary, ethical, casual, charitable arrangements that supplement, if not substitute, for government. So let me just end very briefly and just kind of point you to the things that I hope we can talk about in the question and answer, which is we now find ourselves in a situation where we perform badly as a country on health, and we waste $1 trillion a year. Let's be blunt. We waste $1 trillion a year. And so competition is, I think, our way out, as is innovation. The challenge is innovating and competing on things that actually do us good. And so what I would like to just flag for conversation tonight are two things, prices and products. And I'll leave it at that. Thank you.
Thank you, Professor Sagan. We will begin the rebuttal phase of the debate. I'm going to start off again with Professor Avik Roy.
Well, since I was strident in my opening remarks, let me be somewhat more conciliatory in my comments, which is to say, just to be clear, I actually support universal coverage. I certainly believe that we should have a safety net for the poor. And I think where I strongly disagree with Arrow is that the Arrow argument effectively is that, well, the laws of economics simply don't work in healthcare, so we have to do something else. But what that something else is not firmly rooted in actually human behavior and human incentives. And the thing is, if we actually step back and we understand how human incentives work across all disciplines, across all industries, we understand where our healthcare system goes awry and how other people in other countries sometimes do things better. And that again goes to this point about health savings account. One of the great innovations of the last several decades has been the proliferation of health savings accounts as a way to encourage people to pay directly for their own coverage, sometimes subsidized by the government in order to make sure that poor people also have access to those funds. But if you do it that way, and you convert insurance back to what it was meant to be, which is to say, the way we buy insurance across industries, right? Why do we buy car insurance? Why do we buy life insurance? We buy insurance to protect against unpredictability, but for catastrophic financial loss. So we want to be protected from catastrophic financial loss when we buy insurance of any kind, including health insurance. But the fact is, the vast majority of healthcare isn't catastrophic financial loss. So where Arrow is strongest, he says, well, look, if I want to take Arrow's side, I'd say this. If I'm unconscious because I've just had a heart attack, okay, I can't really shop for care. That's true. You can shop for insurance that covers that, however, and that's where the third-party example is appropriate. But for 80% of all health expenditures are not for things where you're unconscious. They're for things like knee surgeries, checkups, preventive care. For those things, the second-party model of direct spending really works. And if we learn from that, we can make healthcare massively more affordable than it is. In Singapore, for example, where they have this system, they spend 1/7 of what we spend on healthcare. We'd wipe out the budget deficit today if we adopted something like that. Now, that's not a libertarian utopia, but it's a much more market-oriented system than the one we have in the United States.
Thank you, Professor Roy. I'd like to move on to Professor Sam Richardson for his rebuttal.
Yeah, I'll use my rebuttal to talk for a couple of minutes about the problems with insurance competition as we see it. So I'm an economist. I believe in competition. I believe that providers should be in competition with one another. I believe that competition should be regulated in various ways. But I think that the competition in our system should be between doctors, between different hospitals, between different facilities. The problem with competition between insurance companies is the way the insurance company makes money is by getting the relatively good risks. So if you're charging a certain amount, you need to attract the people who are going to cost you on average less than what you're charging. Now that's true across a variety of insurance systems. So car insurance companies, they want to attract the relatively good risks, and they want to get the people who are going to, on average, have fewer accidents. The problem with the healthcare system, or the health insurance example, is that there's a much wider range of expected costs for people. If I have diabetes, I'm uninsurable. Now, that's because insurance is for protecting you against an unexpected change in your health status. If I have diabetes, I need health care. I don't need health insurance. But I think that in our society, we care about those who have diabetes. We don't want them to be shut out of the insurance market, which largely was the case in the pre-Affordable Care Act world, where if you had a pre-existing condition, it was very difficult for you to get insurance because you were no longer insurable. Insurance serves two purposes. It's both, health insurance is both protection against risk, and Avik is exactly right when he says that it's about protection against risk, but it is also a way that we can help people who are relatively sick. It is a transfer from people who are lucky enough to be healthy to people who are unlucky enough to be sick, and I think that the government has a role in facilitating that eminently just transfer.
Thank you, Professor Richardson. I'd like to move ahead to Professor Pauly.
Okay, three points. One is, I think Sam is wrong about insurance. So insurers make money by selling insurance for a premium higher than claims, and they can make money off of bad risks as well as good risks. They just charge them a higher premium. That's what happens in the individual health insurance market. If I'm an older person or if I have bad health habits, under the regime pre-ACA, I have to provide that information, and I'll be charged a higher premium. They'll make money off of me just as if I was still the bronze Adonis I was when I was a young man. So it's going to work out either way for them, but there's a lot of competition. So although individual firms will try to make money, if they all were to go after the low risks, they would end up bidding down the premium for low risks, so that it would be a good deal if you're a low risk, which is fine. We should reward healthy people, but not otherwise. The second point, so when do insurers want to go after the low risks and avoid the high risks? It's when you have what's called community rating, which is part of the Affordable Care Act, a big change that says we're going to charge everybody the same premium regardless of risk. Then if I'm an insurer, sure, I don't want the money losers, the wheelchair brigade showing up and signing them up. I'm going to lose money on them. I want to go after the healthy people, although exactly how I do that is a bit of a challenge. But that's the consequence of government intervention that forced insurance premiums to be uniform rather than based on risk as they would be in a competitive market. why is community rating in the Affordable Care Act? It is for the reasons Sam mentioned. I think all right-thinking people would want to make transfers to people who are unlucky enough to become high risks, particularly if it's no fault of their own and it was uncertain beforehand. But in my view, community rating is the dumbest possible way to do a good thing. The good thing is to make a transfer to high risks. What's a smart way to make a transfer to a high risk? Is create a high-risk pool, tax general taxpayers, so tax the rich, tax the people who can afford to pay, not the young folks who are going to be overcharged grievously under the ACA. Tax me to pay for the high risks. Take away my tax subsidy too, and the consequence of that is that then young people won't run screaming away from the exchanges because their insurance is, at least in some cases, very substantially overpriced. The third thing I just have to say is I think international comparisons are useless, if not harmful. And if somebody wants to ask me later why I think that, I'll be happy to tell you.
You're going against your own teammate, too.
I understand. Well, that's a bipartisan insult. So.
Okay. Lastly, on the con, Professor Sage again.
Well, so I won't spend much time with Singapore, Avik. It is kind of shooting fish in a barrel. The thing you want to know about Singapore is that it's heavily, so there are a lot of mandated contributions in Singapore. So everyone is forced to pay substantial amounts of income into the system. There's significant redistribution between the wealthier and less wealthy folks, and they're fairly stringent controls and norms set on the availability of services, not at the point of care, but in terms of the design of the system. So not really kind of a free market example. But let me spend more of the time just trying to disabuse you of the notion that health savings accounts are something wonderful and special. And here I'll actually be conciliatory in that the recent dust-up about cancellations under Obamacare is kind of, does every insurance policy have to have the somewhat greater coverage and less cost sharing that's in the ACA, or might they have somewhat less coverage with somewhat greater cost sharing? And I do not think there's an ideological position on this. I think there was a great deal of room for negotiation, and I might well have been comfortable with a different outcome of that than ended up in the ACA. So, could people have more cost sharing, and could there be some separating equilibria that make it not pure community rating? I'd probably be okay with that. But I don't want you to think that a health savings account is really the answer. I mean, a health savings account takes a very clear economic theory, which Mark Pauly was one of the first to really develop, of moral hazard in economic rather than emotional and moral terms, and apply it to a policy intervention which said that if you spend your own money, you'll spend it more prudently than if you spend someone else's money. So far, so good. Problem is that given where we have put ourselves in the healthcare system, simply telling consumers who face high and arbitrary prices that they now should take care of their own spending is not really going to get us very far. So it is a theoretically intelligent solution that was politically operationalized, but I think, at best it is a partial solution. You also should understand that it's not just that health savings accounts have been designed over the last 15 years or so to appeal to the healthy. They've actually been quite specifically designed to appeal to the rich. I don't know if this is currently the case, but for many years, health savings accounts at the federal level enjoyed something no other form of deferred compensation or investment enjoyed, which was a double tax subsidy. It was non-taxable or tax deductible when contributed, and the appreciation on the amount that you put into your savings account was not taxed either. So this really has been something that has an interesting intellectual pedigree, but mainly a great utility to people who seek financial profit rather than health advantage, and I don't think you should look at it as a panacea.
I want to thank the panel for their initial presentations, and now we will move to the Q&A part of our program. Before I do that, however, I'd like to announce something that happened before the presentations. There was a pre-debate vote, pro and con. Of course, again, the resolution was healthcare markets are not unique and do not require extra government intervention in order to function. Of the 70-plus votes, a little over half, 38 people were con, or no, on that proposition. 19 were pro, and 15 were wishy-washy. Okay, I would like to really encourage a lot of informal questioning. I'm going to start by asking a question or two that has been pre-submitted, and then hopefully we can get lots of participation from the audience. If you do have a question that you don't want to ask formally, you can certainly bring it down, and I'll probably ask it in that form. Let me start with a question that pays some homage to Kenneth Arrow. By the way, this is about 34 pages long, and it cost me about $10 to get it, unfortunately. Maybe it apparently is free to these wonderful professors, but if you want it free, I have it now, and I'll send it to you if you email me at campbellf at the Health Science Center.
We'll even pay you to take it, read it.
It is well worth the reading. Okay, this question can go to anyone. What significance for the resolution do you see in Arrow's personal ideologic migration, continuing in the decades after 1963, away from socialist views and toward support of a mixed economy? Who would like to take that? Yes.
Well, I'm sure that Bill and Mark, who have much more contemporary with Arrow's work, would have a lot of interesting things to say about this. But I think I want to use that to respond to something that Bill said in one of his comments, which is that Arrow was saying in the paper, well, it is obvious that America finds it intolerable, the laissez-faire situation in healthcare intolerable, and that this was just some sort of distant observation, neutral observation that had nothing to do with Arrow's own preferences. And I have to say I disagree with that. I read that sentence as, well, maybe among the people Arrow associated with, it was obvious that, there used to be these things they said about the Nixon years, that people would say, well, I can't imagine how Nixon got elected president. I don't know anyone who voted for Nixon. And people said that about Reagan, too, in a lot of concentrated areas where a lot of people who didn't vote for Reagan lived. And I see Arrow's comment in that light, which is to say there are plenty of people, particularly in the 1960s, when things like Medicare and Medicaid were so controversial when they were being debated and passed in 1965. There were plenty of people who argued for a more laissez-faire approach. They didn't win that argument at the time. And it's certainly true that today, making the American system more market-oriented is politically difficult, and making it less market-oriented is also politically difficult. And I think that Arrow's evolution in that regard reflects a lot of people. In fact, if you talk to a lot of people of Arrow's style or temperament today, there are people a lot like Bill and Sam who would say, you know what? Single payer is not the only solution. There are a lot of ways to get to universal coverage, and I'm open to many different solutions. And similarly, I think you see on the right a convergence in that regard, and you see a lot of people on the right say, look, our current system is really inefficient. We could take the same amount of money, cover everyone, and have a more market-oriented approach. And ideally, that's where we'd all end up, somewhere with a policy, but that unfortunately has not been the case to date.
Anyone else want to comment on that particular question?
Well, so I think, like many young people at the time, Arrow started out very left of center, but by the time he wrote this article, he was what he is now, an economist, and was basically reflecting the views of the profession at that time. And as I mentioned, those views were to be, and I think this probably helped, I don't know his own personal story, but probably helped to lead to the conversion, understanding that markets actually could be a solution to the problem of not only efficiency, but even with proper care and feeding justice in a society. But the step that he didn't take, which has been taken since then, and by my advisor, Jim Buchanan, also won the Nobel Prize, Jim pointed out it isn't reasonable to assume that governments are run by angels sent down to earth. Let's assume they're run by people who want to do things like get reelected or get campaign contributions. When I explained to my mom, well, that's why Professor Buchanan won the Nobel Prize, she said, that's nice, dear. But I don't think she was that impressed because she kind of knew it. And it was only economists who somehow had this mindset that government should do what we think we want it to do rather than what it will do in real life. And I think there has been a substantial change. Of course, not affecting all economists, certain ones you could think of who still believe that the government is a solution to everything, but I think there's been a much more skepticism of the ability of governments to necessarily do better than the market. After all, in theory, a perfect government at best ties the market and beats it almost every time, but that can't be an operative theory for structure of society.
I just add, Arrow is writing in the subset of economics that's been called welfare economics, which may be coming back a little bit into fashion, but was out for quite a long time because it was much harder to model empirically and reach definitive conclusions. And so Arrow doesn't really display many definitive conclusions in this article. It's very thoughtful, and he goes back and forth on a variety of topics and kind of plays with them to see where he ends up. And I think Mark Pauly's work, contemporaneous and a little later, often does similar things. I mean, these are not necessarily issues that can be cleanly resolved by economic logic. What makes Arrow's article so interesting in many ways is that it really was sort of a brilliant economist and sort of a moment in time, describing things, some of which were already outdated by the time he described them, some which he couldn't possibly anticipate in our modern situation, but kind of bridging the gap nicely. He was interested in this and accepted the commission because he had worked for a summer at an insurance company. And that's all he really knew about healthcare. And he wrote this article, and with one very small exception, he really never came back to healthcare again. So you have this sort of moment of a really smart economist grappling with a very complicated question. Now, here, we just have to be clear on this laissez-faire quote in government. This is... You can read it. It's on page 967 of the original article, just before the postscript. And actually, when he says it, he says he's actually supporting, at least tentatively, certification, a voluntary, non-government, consumer-driven process as a substitute for medical licensing. And he says no one actually entertains certification seriously enough because everyone has decreed that laissez-faire won't work in healthcare. So, I mean, he really isn't making a plea for heavy government intervention. But Arrow's work is worth thinking about because it is kind of not definitive and open to a lot of empirics as well as a lot of reasoning. And because it gets into messy domains, like what do people want and how do they relate to each other, long before we had behavioral economics to model it.
Okay, I've been chastised. From here on, the answers of the questions can only be 30 seconds, so be as succinct as possible. I'm going to try to target these a little bit. I have several questions here. Let me ask the pro side, if healthcare markets are not unique, how did we get into this mess in the first place? This is from a couple of medical students.
Well, lots of markets have imperfections. Healthcare markets are a lot like other repair markets. I differ a little bit from Avik. I don't think health economists, this is inside baseball, but make much of the uniqueness thing. And even Arrow, I don't know if you said it was unique. It's this combination of characteristics maybe is unusual. I don't know if it's totally unique, but it's the health policy types who learned enough economics to be dangerous who fasten on this uniqueness issue to then stomp on markets. But I don't think economists would say that. But I think the punchline really is that there are potential imperfections in all sorts of markets, and then you get back to the debate about is there a government solution that's better than the problem?
I think it comes down to the Hippocratic Oath, actually. The ancient tradition of medicine is one that is very anti-economic. I wrote a piece for a quarterly Journal of Public Policy called National Affairs a few years ago called Healthcare and the Profit Motive. And it talked about this tension between the Hippocratic ideal, which is you treat your patient regardless of not only the physician's interest, economic interest in general, just what's in the best interest of the patient, full stop. And that mentality, that principle, which is a noble principle, extends to the way we train physicians today. Unfortunately, healthcare is very expensive today. So when we train physicians without regard to cost and only the patient's physical health outcomes, we create a lot of unaffordability and inefficiency that makes the healthcare system more damaged down the road.
We got in this mess because we've poured money into the healthcare system for decades now, often pretending we weren't pouring money in when we did, and empowering physicians to declare where that money should go. And as a result, we ended up with a healthcare system, sort of a comment I made casually as we were driving over tonight, we end up with a healthcare system whose greatest talent is the ability to bill for just about everything.
I was afraid the profession was going to get attacked eventually. Let me ask the con side specifically. What examples from the past 50 years show that we have not, contrary to popular belief, had a true free market in U.S. health care? What are the most glaring examples?
Can you repeat that?
What examples from the past 50 years show that we have not, contrary to popular belief, had a true free market in U.S. health care?
What popular belief?
I think
0.6 of a second a year.
I think that the clearest response to that is Medicare and Medicaid. So roughly half of our healthcare spending in this country is government healthcare spending. Medicare, Medicaid, veterans health, a variety of smaller programs. And beyond that, we have all sorts of government regulation of medical licensing, for example, is required from the government, comes from the government. So in a number of ways, but most clearly the amount of money that is spent by the government shows that it is not a free market system.
My 10 seconds would just be, we don't have a real price in the system. If this were a free market, there would be a real economic price that someone pays somewhere in the healthcare system, and you have to work really hard to find one.
Yes, that's a popular belief. It's because people don't understand the healthcare system. I mean, it's never been an unfettered free market. It may be a fettered free market. I don't know what that would look like, but it's never been unfettered. There's been licensure. There's been, as Sam mentioned, local monopoly. There have been patents to protect drug company profits, of course, to encourage innovation. It's only Europeans believe that we have an unfettered free market in healthcare, in my perception.
I'll just give you one statistic, which is that if you look at government spending per capita on healthcare in the United States versus the rest of the world, we spend more per capita on healthcare than all but 3 other countries in the entire world. Norway, Luxembourg, and the Netherlands are ahead of us. That's it. We spend more per capita than the UK, Sweden, Belgium, France, all these countries that we say are the welfare state socialist countries. So if we're free market, then what are they?
Yeah. We meaning the government.
We meaning the government. That's not total spending. That's just public spending.
Okay, here's another one for the con side. What about the doctor-patient covenant? Why trust government? This is, again, from a medical student.
So from an economist's perspective, we can't give all care to all people. Resources are limited. We live in a scarce world. And so rationing is necessary. Rationing is this horrible word that no politician will ever say. But some sort of rationing has to occur because anything that we spend on healthcare is something that we're not spending on something else. And we value things other than healthcare We need to get value for our money. And doctors are largely trained to do everything in their power to help their patients, and that leads to increased spending.
I think you have to distinguish, though, between, people who ask these questions sometimes think, government is over there. It's not. It's not government them, it's government us. We've decreed over a long period of time that we want to pour money in and we want to erect various barriers, restrictions, conditions, and it's not as if we're trusting government to fix the problem. We have used our government, our democracy, both to fix problems and create problems over a long period of time.
Here's a question for the pro side. How can we even talk about a rational market for health care when those who need it the most, the poor, are least able to purchase it? Why is this not a fatal ethical problem for the healthcare marketplace?
Well, I wouldn't say that those who need it the most are necessarily the poorest. I think that people who need healthcare are people who need healthcare, whether you're healthy or sick. It's not really income dependent whether you need healthcare. It is certainly true, as I said, that we should have a better safety net than we do. And the reason we don't is a long historical discussion that starts with Medicare, because we spend all of our resources on subsidizing health coverage for the employed and for the retired, whether they're wealthy or poor, but particularly the wealthy. And that's been a big part of why our system is so distorted. So that is an ethical problem that both Democrats and Republicans have not confronted, and particularly Republicans, I'd say, but Democrats as well. That's why the president said, if you like your plan, you can keep it, because he didn't want to disrupt that system. In fact, he doubled down on it.
So, we should make a lump sum transfer to low-income people to help them afford health insurance. That's not a violation of any principle of a free market. It's an ethical decision. It's not an economic decision, although it has some efficiency characteristics, I think. But at least I take that as a given, and then have a free market when people are appropriately equipped with the resources to outcompete me for good health care.
Let me just make a quick analogy. Food stamps. We don't nationalize the grocery store system. We give people an ATM card effectively and say, go buy food. That works pretty well. We could do that with health care.
Well, we kind of do it for Medicare, actually. Medicare is a voucher system now. The voucher, I dread going on Medicare. That's why I keep teaching. But when I do go on it, effectively, I can choose the government plan, or I can choose a Medicare Advantage plan whose dollar value to the insurance company will be equivalent to what Medicare, the conventional Medicare, would have spent on me. That's a voucher, and the debate, and I actually think there's very little difference between the administration and Paul Ryan on this, is, well, in the future, we're going to have to convert that to a voucher that isn't tied just to what the conventional Medicare plan doctors and patients agree on, but to something the government and the people can afford. But there'll be a voucher available to you as a senior citizen, and you can either use it for the government-run insurance, that's if you like the post office, or you can use it for Medicare Advantage, that's if you like FedEx. And,
Let me get a question from
Medicare for all. Let's do it.
Let me get a question from the audience.
Mr. Pauly, would you explain why the international comparisons for statistics on healthcare options?
Thank you. Okay, sure. So there's two things to be said. Sam said them. We spend a lot more, and we get worse health outcomes. Why do we spend a lot more? The New York Times version is it's the price is stupid. The Wall Street Journal version is it's the wage is stupid. We pay our people in healthcare, not particularly physicians, although orthopedic surgeons, yes, but not primary care. But we pay everybody in healthcare higher wages than they do in other countries. It's those greedy phlebotomists that are the cause of our healthcare spending is a fraction of GDP, exceeding that in most other countries. We actually did this calculation. If you calculated what would our healthcare cost be if we paid people like they do in Denmark, you would not quite take away all the difference between us and Switzerland, but you'd take away about 70 or 80% of the difference. That's on the cost side. So most of our cost difference is not cost, it's price. The other part about outcomes, the reason we have terrible health outcomes is because we have a terrible dysfunctional social system with a large fraction of poorly educated minority populations engaged in behavior that's harmful to their health. And most other countries don't have, if they have a minority population, of course a lot of them are having growing minority populations and they're worried about it, but it's not anywhere near ours. And they have a much stronger social safety net. The best miracle drug, after all, to keep people healthy is money or income, and they redistribute that more evenly than we do. So, and for that matter, the reason why they have such great health outcomes in Singapore is because 80% or plus of the population are middle-class Chinese. Singapore is like Denmark, but with high humidity. But the population there engages in very healthy behavior. The income is fairly evenly distributed. There aren't extremes of rich and poor. As Sam mentioned, the requirement to make a contribution toward a health savings account, it's required, it's mandatory, it's not voluntary. Bill, whoever mentioned that. But there's a whole long story, but the reason they get good health outcomes in Singapore, I think, has almost nothing to do with their healthcare system and has everything to do with their ethnic mix and their culture.
Can I respond to the Singapore bashing?
Yeah, very quickly,
Just being
please.
jocular
Got a couple
here.
more questions.
I'm sure that the Chinese lifestyle habits and the Tai Chi or whatever they're doing is helping their health outcomes, but it doesn't explain why Singapore spends 1/7 of what we spend.
Well, they don't pay people very well.
So I think a big part of it is the fact. So this whole issue of, well, they're taking money away from you and forcing you to save money for your own care. That's better than taxing you at 30% and then giving it to bureaucrats. So I actually think requiring people to save for their own health care is much more optimal and much more efficient than taxing them and spending that in some way that they don't control.
Okay, here's a question for both sides. What resources best help patients choose their physician or practitioner or their hospital?
And while they're thinking about that answer, I just wanted to explain, I'm going to pass some bags, and you'll remember that when you came in, we gave you 3 cards, yes, no, and maybe. So this is the time for the post-debate vote after you've heard everything. Now place your post-debate vote. And if you guys want to ask questions, please feel free to line up at the microphones.
Okay, no more stalling. What resources best help patients choose their physician or hospital?
Which side was this directed to? I'm sorry.
Anybody can take it.
Well, I think, again, the Internet revolution is having a huge effect on this and will continue to. There are increasingly independent third-party resources. There are government resources, too, that rate hospitals, that rate doctors. Those resources will continue to expand, and we should promote that process. And frankly, the physicians and the hospitals have been against that for a lot of reasons that are understandable if you're a physician or a hospital. But we need to encourage that. One of the biggest problems I think a lot of us agree on at this table, one of the real menaces in our healthcare system is hospital consolidation that's leading to less competition among providers. That's really what's driving up a lot of the costs in the healthcare system, is that the hospitals can gouge everybody. They can charge whatever they want. The insurers have to roll over and accept it.
I think one of the problems is, except in some specialties, it's very hard to measure what doctors do. And there's a lot of uncertainty around what a doctor's panel's outcomes are going to be. There's a lot of noise, and so if you are getting penalized because your patients get sicker, you could have just gotten unlucky. Now, that being said, there are some areas where the outcomes are pretty clear-cut. If you're a cardiac surgeon, you can see how sick are your patients, how many of them died, how many of them would have been expected to die if an average surgeon had had this mix of patients, and we can do that measurement fairly well. That's what we care about in that situation. But I think it's very hard for any of us to say that one particular resource is going to say this is the best doctor or this is the best hospital.
That's a practical, worrisome problem, but I think from a health policy perspective, it really doesn't matter. A much more important question is how to get people to choose sensibly among insurers, especially as insurers are moving back into more narrow networks. And to some extent, then, what insurer you choose picks your hospital and doctor. Beyond that, well, when I spent a year at Stanford and had to line up a primary care doctor, they gave me this long list of all the physician groups out there. And I called up and looked at credentials and things, and finally I realized the only thing to do was to call up and ask who's the young guy, because I was the only person taking patients, and that was fine.
Okay, here's another very basic question. This is from a friend of a medical student. Do doctors even know how much their procedures cost?
They have no idea. And you can ask anyone, and they don't
care.
Well, I guess we have to beg the question, why?
No, they care if their patients care, but they honestly don't know. And you can go from practice to practice, and they really don't know. What you have to understand here, though, is that I like to talk about the upstream of health and the downstream of health. And, you know, by the time you get to an American physician's office, you're way in the downstream. And as a society, we've just been pouring trillions of dollars into downstream health care and wasting, as I said, $1 trillion a year. And this is, you know, not a secret. This is the worst kept secret in American medicine. What we need to do is have the upstream be innovative and competitive. This is the area where you're not a patient, you're just a person, and you're improving your health and maintaining your health and accessing basic services while you live your life. And there's a great potential for entrepreneurship and innovation in that space, and a great opportunity for markets and profits, but we don't go there because all of the easy pickings have been downstream. So we need to liberalize the upstream space and stop pouring money downstream.
Doctors don't know what anything costs because they have no economic incentive to know what anything costs. And that goes to Ken Arrow's real insight, which is that third-party payment for healthcare services makes those healthcare services less efficient. So the response should be to really corral the things that we rely on insurance to pay for and maximize the things that people pay for more directly.
And I would add to this that one of the more recent innovations has been reference pricing, and I think this is moving in a very good direction, which is your insurance company will pay for a given procedure based on what the cheapest or second or third cheapest provider of that procedure is charging. If you want to go to a more expensive provider, you pay the difference. Then all of a sudden the providers do need to care about what things are costing.
Here's a related question. How is healthcare like other markets if consumers can't call around and price shop for labs, et cetera?
It all goes to the same thing. I mean, because we've had this culture for so long of relying on other people to pay for our health care, we haven't shopped. But the more people are, now that HSAs and the like are becoming more and more a part of our healthcare system, you're seeing an increasing amount of people shop for care or ask their doctors for the price of things. And I think that is having a positive effect and slowly changing the culture of physician practice. But it's a gradual process.
Yeah, we don't have slowly. This is not going to work. You know, we're really at a point where if we don't stop wasting money on useless or harmful health care, and we don't start getting ourselves healthier as a society and more economically productive, we are just broke. We're out of public money, we're out of private money, and it's time for urgency, and it's time to not be lost in the details here and start seeing the big picture.
Okay, I'm sorry. Better.
I have a question about pharmaceutical policy, probably for the Con team. Libertarians love to complain that the FDA has a ban on drugs that haven't gone through these big hoops, but I've been wondering if there's a consequence of the FDA on the flip side. A lot of people say that Americans are over-medicated, and because of FDA policy, we basically have, everybody in the room, everybody in the country has heard the phrase safe and effective. The FDA basically has a charge from the federal government to declare all the drugs that you can buy are safe and effective. I think everybody in this room probably thinks that's maybe a bit going too far as a phrase. You know, physicians know drugs are dangerous, right? But the common man thinks everything is safe and effective, or do they? Do you think there's a relationship between FDA approval and over-medication?
I don't know if I wouldn't venture to say whether the FDA is leading to over-medication. What I will say is that one problem with the FDA is that they are by nature risk averse. So an economist would approach the drug approval process and say, there are costs to both false positives and false negatives. That is, there are costs to approving drugs that end up being dangerous, and there are costs to failing to approve drugs that would be helpful. And the FDA tends to be much more averse to the false positive, where they approve a drug, it ends up being dangerous because that's what ends up in the news. And I think that this is an area where an economist's perspective would lead to better outcomes.
Let me say two things about FDA in the big picture. One, it's interesting what FDA regulates and what it doesn't. It regulates drugs. It does not regulate medical practice. And that political settlement is a very interesting thing to consider. The other thing is that the FDA at its heart is an information agency, not a substantive regulatory agency. And this is turning into a serious problem these days, or let's say a challenge, because we now have a Supreme Court that is very, very protective of all First Amendment free speech rights, including those of corporations, which is making it very hard for the FDA, even in its own terms, to function as an information agency regarding marketing and things like that.
I think the main culprit in over-medication has to be physicians, right? I can't go out and get a prescription drug on my own. I've got to get somebody here to write me a prescription. And so in the first instance, if you people wouldn't do that, we wouldn't be over-medicated. Now you will tell me, and you will be right, given what they're paying me, especially if I'm a primary care doctor, it's not going to pay for me to take the 15 minutes to talk Professor Pauly out of the drug that he wants to get, especially if I think it's fairly benign. I'll just write a script and then I'll be able to see my next patient. But that's a fault of insurance design and care organization, not a fault of the FDA. So I'm not surprised to hear myself defending the FDA, but in this case, they're not.
To follow on to that,
will leave this room, by the way.
To follow on to that, as they say, the most expensive medical technology there is this, in the hands of a physician.
Or the telephone.
Or the telephone.
Let's get another question from the audience.
I heard it said multiple times that we as a society have deemed it unacceptable for those who can't afford health care to go without. So I'm wondering, if that were the case, then why do we need the force of government to impose that upon our society?
Why not just have charity care? Is that basically the argument?
Well, essentially, if society's decided that it's unacceptable for the poor to go without health care, then why do we need the government to play middleman in that?
It's a tragedy of the commons problem, where I don't want people to be dying in the street, but me donating $1,000 is not in itself going to stop people from dying in the street. We need some sort of collective action to get the resources to be able to avoid that. So it's a problem where if we were letting everyone decide how much to donate to charity for this purpose, people would underdonate because anyone could free ride.
You know, the thing I would say is that as far as state interventions in the economy go, ensuring that nobody dies in the street is a pretty trivial expenditure. We already actually, in 1986, I think, Reagan signed into law the EMTALA, the Emergency Management, Treatment, and Labor Act, which required all hospitals that accept Medicare funding to take anyone in the emergency room regardless of immigration status or ability to pay. That was kind of in fact, we have universal care in that sense, right? That if you do get hit by a bus, you aren't going to die in the street. You will get covered. We should have done that more transparently through the tax system than we did through the mandate through the law. But the thing is, if that was the only problem that we were trying to solve, we could do that with a trivial amount of expenditure and a trivial amount of regulation. Unfortunately, our system tries to do a lot more than that, and that's why it costs $3 trillion a year.
One last question from the audience, and I have a couple left.
I have both a comment and a question. To me, it seems like the question posed to the panel is almost too black and white, and I think we run into a danger listening to the economic arguments here, where we might be thinking that those who are con are actually in favor of the Affordable Care Act, and maybe you are, maybe you aren't. But if we were to take it a step further away from this black and white mandate to do this debate, let's talk about the government taking over 1/6 of the private sector economy and the Affordable Care Act as their solution, the government solution, for what's wrong with our healthcare system. And we only need to look at the rollout and the fact that more people have lost their insurance than have gained insurance, and the mandates are not necessary for a large majority of the people that they're requiring to pay for those mandates. And so I guess my question is, if the question were stated differently to you as a panel, would the people who are con the statement Are you feeling that the Affordable Care Act is the solution for what's wrong with our healthcare system? And if so, why?
Well, I won't have to ask that question. I was going to have you put on your ACA hats. Quick answers. Quick answers.
As some of you may know, I defend the ACA, or at least explain the priority list the ACA creates, using 4 images: a magic wand, a $100 bill, the ballpoint pen Sam alluded to, and a box of McDonald's French fries. What you need to know about the Affordable Care Act is it tries to solve 2 quite solvable problems about uninsurability and unaffordability of insurance, and then tries to at least tee things up to solve 2 much harder problems, which is the wastefulness of American healthcare and the poor underlying health of Americans. If we don't at least discuss all of these issues rationally, we may never get out of the easy ones into the ones that really challenge us as a society economically and in other important ways.
I think that getting everyone covered is sort of the easy question, and I think whichever way you want to go about doing that, there are a bunch of reasonable ways to get everyone a minimum level of insurance coverage. The real tough questions, and I don't think that the Affordable Care Act does nearly enough, are how do we improve the quality of care and how do we reduce what we're spending. And the Act makes some statements in that general direction, but is not really going to address the cost and quality issues in a meaningful way.
Yeah, I think we reduce the cost by reducing the quality of care, and we should. It should reduce the quality of care that I get, not for low-income people, but for me. My quality of care is much too high, and that's because I get this big tax break, so why not? But in all other industries, efficiency has been brought about by people introducing new products that are a little less good, but a lot cheaper than the previous one. This is called disruptive innovation. Xerox machine is a great machine. It has all sorts of bells and whistles, but Sharp and Canon were introduced at a much lower price and dramatically improved the affordability of copying machines in the United States. And I think we need to do the same thing for healthcare. I think we need to stop talking about improving quality and talk about what dimensions of quality are important to preserve and what dimensions of quality aren't worth what they cost, and we should get rid of them.
You know, it's funny. Among my liberal friends and in the media, I'm seen as the guy who's the relentless, unstoppable critic of Obamacare, who's always talking about everything that's wrong with this law. But the irony is that I'm also pretty outspoken in saying that I don't think it's an existential threat to America, which is actually a pretty common conservative position. I actually believe that the law will never be repealed, and that that's not necessarily a terrible thing. That the Obamacare exchanges are actually exchanges are a reasonable way to deliver insurance to a broad range of people, including low-income people. I don't think that the ACA exchanges were designed very well. That's why I criticize them a lot. But I criticize them a lot because we have a huge stake in their success as friends of a more market-oriented approach. Because if we'd like choice and competition, exchanges can be the way to deliver it, and what we should do is actually dramatically reform those exchanges, and then expand them to these other groups like Medicare, Medicaid, and the employer market that aren't in exchanges today.
You've been a tremendous audience. I haven't come anywhere close to asking all the questions, and I am not going to run over. I do have the results of the post-debate, I guess, voting. But I want to ask a legitimate question right here on the question sheet. Of all 4 panelists, you have a one-word answer, yes or no. Is access to adequate health care a basic human right?
No.
I don't know. We don't have the evidence.
No, maybe?
Yes.
Yes.
Yes. Okay. For those of you that voted, and there was over 70, a lot of you came off the fence, and you came off the fence to the pro side. 26 yes this time. And those of you that were no, I mean, this could have shaken up a little bit, but uncanny number 38 again, no, and 7 maybes. I've had a great time tonight, and I thank everyone that's here, and I certainly thank our distinguished panel. There's been an awful lot of light, I think, as well as heat, and so continue to be interested. And like I said before, this is a landmark article. I am stunned and awed by the genius of this man in 1963, who predicted an awful lot that's going on right now. So feel free to email me, and I'll get it to you.